عرفش الكلام ده ما اشتغلش نيونيت صراحه. واللي برضه اللي مش بيشتغل نيونيت ما يعرفش ريتينوباثي اوف بريماتوريتي ما ينفعش. ليه بقى؟ عشان الدكاتره اللي اتسجنوا في الاخر. فانا هقدم دلوقتي الاستاذه نهال الشقنقيري، استاذه امراض العيون بجامعه الاسكندريه، وانا طلبت منها الموضوع دوت وهي وعدتني بيه، موضوع ريتينوباثي اوف بريماتوريتي. لان ايه؟ مؤتمر الجمعيه الشرعيه يؤجل عشان الكورونا، ان شاء الله السنه الجايه هنعمله باذن الله. الاستاذه الدكتوره نهال الشقنقيري، استاذ امراض العيون بجامعه الاسكندريه، ريتينوباثي اوف بريماتوريتي، يعني موضوعات اثنين مهمين جدا لكل الدكاتره اللي بتشتغل في الحضانات. اتفضلي حضرتك يا دكتوره نهال.
بسم الله الرحمن الرحيم. Before I start, I'd like to thank Professor Ahmed Ismail for his kind invitation for me to participate in your meeting. And I'm going to speak about retinopathy of prematurity. ROP, or retinopathy of prematurity, is considered to be 20% of childhood blindness. And it is considered as the second most common cause of childhood blindness. You as pediatricians, unless you are aware of the magnitude of the problem, you will definitely see blind grown-up children walking across your clinic in the future. And we as ophthalmologists, unfortunately, we frequently see this picture. Infants and children coming from blindness, suffering from blindness, and complaining of this, what is called eye-poking sign. They press on their globe. They are totally blind. They press like that on their globe. So they form a sort of irritation of the photoreceptors. So it induces a false impression of light, as if they are perceiving light, but they are actually totally blind. And we commonly see referral. Here it is referred as bilateral congenital cataract from a pediatrician. Yes, it looks like congenital cataract, but actually, again, the baby is producing an eye-poking sign. It means that he is totally blind, and this is not congenital cataract. Another baby referred as congenital cataract. A third baby congenital cataract, and all these are retinopathy of prematurity. And when we go for ultrasound, this is a funnel-shaped retinal detachment, stage 5 retinopathy of prematurity. And sometimes they come with complications of anterior segment, and again, totally blind. We will start by the pathogenesis and how to diagnose it and how to management and how to go for the management, and actually how to decrease the incidence of retinopathy of prematurity. This is how it appears, the normal retina of a child. This is the optic nerve, and then we have the retinal vessels. They arch upward and downward, and they go like that around an area, and this is called a macular area. And here the dark area, it is called the fovea. During intrauterine life, this is the optic nerve, and there is no retinal vasculature. A state of retinal metabolic hyperactivity induces a state of hypoxia intrauterine. So VEGF is produced. It is a vascular endothelial factor. And the second thing, there is an insulin growth factor. One produces what? Produces retinal vasculature, normal retinal vasculature. It starts at the level of the optic nerve like that. Here, the stump of the blood vessels appears. It goes upward and downward. And then the retinal vessels goes anteriorly, more anteriorly, until it reaches anteriorly here what is called the ora serrata. So all the retina is vascularized. What happens when the baby is born preterm? When the baby is born preterm, the retinal vasculature didn't reach yet the anterior part of the retina. So there is part vascularized and there is part avascular. Immediately after the baby is born, there is a massive decrease in the insulin growth factor, because we all know that the insulin growth factor increases very high level in the third trimester. So it decreases massively after birth. Also, when you give oxygen supplementation in NICUs, this produces a state of hyperoxia. As a result of this, what's going to happen? Decrease in the VEGF. So stoppage of the normal retinal vascularization. No retinal blood vessels will proceed anteriorly. So the second phase of ROP begins. We have here a part of the retina which is not vascularized. What's going to happen? A state of hypoxia. Hypoxia will induce again VEGF, vascular endothelial growth factor, but this time will not produce retinal vessel, normal retinal vasculature growth. It will produce abnormal retinal vascularization, which is thin and liable to bleed and associated with fibrosis. As a result of this, what's going to happen? Intraretinal new vessels will begin to grow. We will have a line. We will have here a line. And then more vasculature, abnormal vasculature. The retina will elevate like that. It's a sort of a ridge. More and more production of these abnormal vessels. And the abnormal vasculature becomes evident on the anterior surface of the retina. So it's a ridge with extraretinal vascularization. This fibrovascular proliferation will pull over the retina. It will detach the retina, which is stage 4, as we're going to see. And then more pulling of the retina forward. So the retina will be totally detached. Stage 5 retinopathy of prematurity, leading to total blindness. This is the normal fundus picture of a newborn. As you see here, this is the optic nerve, and these are the retinal vessels. And as you see here, the grayish area, this is the avascular retina. It is not yet vascularized. We call this stage 0 retinopathy of prematurity. As we said, the neovascularization growth inside the retina, leading to a line separating the vascular retina from the avascular peripheral retina, which is demarcation line or stage 1 retinopathy of prematurity. The line will increase more and it becomes elevated up the surface of the retina, so becomes a ridge, demarcation ridge or stage 2 retinopathy of prematurity. Now the extraretinal fibrovascular proliferation is above the retinal surface. It's a ridge with extraretinal fibrovascular proliferation, which is stage 3 retinopathy of prematurity. Now there is separation of the periphery of the retina. This is the white thing, it's fractional retina detachment. And finally, stage 5 retinopathy of prematurity, which is a funnel-shaped retinal detachment. The retina is totally detached, fibrotic and necrotic, leading to total blindness. And total blindness in infants and children, you will not see these in NICUs. You will see them later on when they come to ophthalmologists or they come to your clinic totally blind. And this, as we see here, from the eye pucking sign, the excessive eye pucking sign, they usually press on the eye globe. They lead to a sort of atrophy of the fat around the eyes, so they appear with sunken eyes. So you have a child with sunken eyes and this eye pucking sign, you should expect that he was preterm and he had a retinopathy of prematurity. What are the risk factors for retinopathy of prematurity? It's actually the smallest, the sickest, the most immature. The gestational age, of course, less than 1,500 grams are liable to develop retinopathy of prematurity. Low birth weight, less than 31 weeks gestational, the gestational age less than 31 weeks, and the low birth weight less than 1,500 grams. Poor weight gain, this is very important, very important. Poor weight gain indicating that this baby, this infant may develop or have a high risk of developing retinopathy of prematurity because it is related to insulin growth factor. And now recently they are trying to make a sort of a nomogram, cooperating the three together, the gestational age, the low birth weight, and also the poor weight gain. And you can predict in advance whether this infant will develop retinopathy of prematurity or not. Respiratory distress syndrome are liable to have. These infants should be examined. Those with intraventricular hemorrhage, neonatal sepsis, those with anemia, those treated with blood transfusion or taking erythropoietin, these infants should be examined. They have the risk factor for retinopathy of prematurity. Drugs as dopamine or endomethacin, and of course, oxygen supplementation. Acidosis, there is no still clinical evidence done in ophthalmology to prove, but it is considered to be one of the risk factors. And if you have a triad of high PCO and high PaO2 or low pH in the first 3 days of life, there is increased risk of severe retinopathy of prematurity in these infants. Now, who do we screen? The low birth weight, less than 1,500 grams, but actually in our developing country, I tell you, it is 750 grams. Early gestational age, and this is in the developed country, but here in our country, it should be not less than 32 weeks, but actually less than 34 weeks. And those full term, but they had oxygen exposure for more than 50 days, they should be screened. When do we screen? The initial exam should not be immediately after birth. No, at the time of developing of retinopathy of prematurity, and this is 4 to 6 weeks postnatal or 31 to 33 weeks postmenstrual age. The frequency, is it just one? No, it should be every 2 weeks. How do we screen the premature babies? Of course, we use special mydriatics. We dilute these eye drops. We should not give the usual mydriatics because they're very dangerous for the heart, especially the phenylephrine, which we go for a dilution. We dilute it into 2.5%. And with the aid of the nurse, we wrap the baby, and the baby is held like that between the arms of the nurse. It's very simple, without, of course, general anesthesia. And we use a special speculum designed for preterm babies. We don't use the speculum which is for infants and children, because you may actually endanger the palpebral fissure in these infants. And you have one for the right eye and one for the left eye. We use actually the indirect ophthalmoscope, which is a cheap instrument. This is just for 30,000 pounds. And we use, there are many lenses, but the ideal lens to be present in NICUs, it should be the 30 diopter Volk lens, which actually gives a good visualization of the vascular and avascular retina. We use clearer indenters, but when we come to train a new trainee, we advise them to use the cotton tip applicator. هم used to take swabs in the bacteriology. علشان cotton tip applicator is very soft to the eye. If they use a sort of a forceps, maybe we've been working like that for years, but they may pierce the globe of the infant and they may cause rupture globe. So it's better if they're going to examine these babies in NICUs to use these cotton tip applicators. And then here you can see that the baby is being examined. This is the lens, and here how we press along the globe. Or we can examine them with the red cam, which is the first wide field pediatric retinal camera. It's a huge camera like that, and the camera is put over the cornea of the infant, and it gives you an idea about the whole retina. This is the disc, and these are the blood vessels. And you can see here the line. This is the demarcation line. This is stage 1 retinopathy of prematurity. How to treat? I'm not going to, of course, go into details of the treatment because you're not ophthalmologists, but I want to press on one important indication. We have what is called aggressive posterior retinopathy of prematurity, or rush disease. If you see here, can you see this is stage 2, and in this eye, stage 3. There is here hemorrhage, there is a vascular ridge, and there is marked tursosity of the retinal vessels. This is called plus disease, and it is present around the disc. If you see this picture, we call it aggressive posterior ROP. If we don't treat these cases within 48 hours, it will end into blindness. They go immediately into stage 5 retinopathy, prematurity, and they cause irreversible blindness. So it is an extreme emergency, and the window of treatment is just a few hours. That's why babies or infants are sent to our department immediately. They need treatment in their incubators, and we provide treatment immediately. We have the line of treatment, which is laser photocoagulation. The principle of laser photocoagulation is that we provide laser in order to ablate or destruct the non-vascular retina, which is the cause of production of VEGF, which will produce abnormal retinal vasculature. To how to go for a treatment, we destruct these areas by laser under general anesthesia, of course. And of course, there should be a good pediatric anesthesiologist to put these infants into sleep. And the treatment is provided by a special retina specialist, pediatric retina specialist. Not any retina specialist can go for this. He has to be acquainted to deal with cases of preterm babies or retinopathy of prematurity, and they provide laser treatment. We have the diode laser treatment, and here how laser is being directed to the eye of the infant. And recently in Alexandria University, we have the double frequency YAG laser. It is a green laser that provides retina, that provides or ablate the retina of infants without destruction, extensive destruction like the diode laser. And we were first in Egypt to have this green laser for the treatment of retinopathy of prematurity and also retinoblastoma. And of course, in Alexandria University, all treatment is provided totally free of charge. And this, the retina, how it appears after laser and ablation after laser treatment. The second line of treatment is intravitreal anti-VEGF. We inject drugs inside the eye by special needle like this. We penetrate the eye and inject it inside the vitreous in order to stop the abnormality of neovascularization of the retina. طيب. If a preterm baby is to be discharged, why are eye exams recommended even after discharge from hospital? يعني لازم كل preterm babies, even if they're perfectly okay and going home, you have to refer to a pediatric ophthalmologist because late eye problems may occur, and these are myopia. They may develop a myopia, a very high myopia. Unlike the conventional simple myopia, it is present early in infancy. They may develop strabismus or squint, and this is very common to have the preterm babies having squint. As we see here, كل دول كانوا preterm infants, and it may develop at any age, and especially we see it in twins. It may be treated with glasses, or we may require even surgical intervention. They may develop late CNS morbidity as periventricular leukomalacia, or they may develop even congenital cataract, as in these cases. For example, for this baby, she was born 1,500 grams. She had a retinopathy of prematurity that was treated, and then she had a congenital cataract that was also treated, and we did surgery for her. And here, 3 months after treatment, 2 years after surgery, after teamwork between neonatologists and pediatric ophthalmologists, retina specialists, and cataract specialists, we were able to save her eyes. Another baby here that's having jaundice, and after she was controlled, this is bilateral congenital cataract. Here, a few weeks after surgery and few months after surgery, the vision was preserved, and we were able to prevent blindness. Another baby here, can you see even the cataract is colored yellow from the jaundice here. And here, after she was treated by the neonatologist, and here, few months after cataract surgery, and the baby was seeing perfect. As you see, all these cases, oh God. As you see, congenital cataract is very common in these preterm babies. If you go for early diagnosis and early treatment, we can save their vision perfectly. So finally, to conclude, we should go for increase the awareness of the magnitude of the problem. We should go for early diagnosis. And of course, something very important we have to combat, the triad of poverty, illness, and ignorance. I see treating congenital cataract after being preterm by, I don't know why, ليه الكحل ده extensive like this, and treating congenital cataract. I don't know what is the mechanism, okay? So we have to combat this triad of ignorance. Number 2, early identification of retinopathy of prematurity should be a standard practice in order to prevent blindness in these children. And there is no prophylaxis, but we can minimize the incidence and decrease the severity of retinopathy of prematurity by improving حضراتكم standard neonatal care. We should decrease the risk factors. Respiratory distress syndrome, oxygen supplementation should be controlled, sepsis. Proper weight gain is very ensure proper weight gain. Breast milk, we have to ensure, which I don't know, they said maybe it's sort of, it may lower the incidence of retinopathy of prematurity, packed RBC transfusion, and you have to control the insulin growth factor 1. Yes, any change, even for the better, is stressful. يعني لازم نغير الكونسبت. احنا مش بندي اهتمام في NICUs to the eye. You have to go for this change. Even for the better is stressful, but they deserve. Look here when we go as a team, preterm baby, alhamdulillah, neonatologist, perfect work, but severe retinopathy of prematurity, and then developing cataract. We were a team, we were able to save one eye and see this beautiful smile 2 years after surgery, and then 3 years after surgery. Yes, she's one-eyed, but at least we saved one eye, وهي دلوقتي في play school. فعلا ومن أحياها فكأنما أحيا الناس جميعا. Nothing in the world worth more than a seeing child to his parents, to his family, and to his community. هنا this baby برضو after teamwork, seeing for the first time in his life after performing many surgeries and coming out of the NICUs, and then we did him the cataract surgery. Here he's wearing his glasses for the first time, seeing for the first time. مرة واحدة هو astonished and then looking, staring like that, and then a beautiful smile, looking to the sides. All of a sudden, he realized that he is seeing a huge smile. What a feeling. الريزلت الأخيرة، الثمرة الأخيرة، إن إحنا نشوف طفل ابتدى يشوف وبيضحك this beautiful smile and then maintaining this beautiful smile. يبقى we have to work all together, neonatologists and pediatricians and ophthalmologists as a team to see this beautiful smile على وجه الملائكة دول. And thank you very much for your kind attention.
شكرا جزيلا استاذه دكتوره نهال. يعني انا سعيد جدا جدا بالمحاضره دي، وعايزين نبلغكم بخبر جميل جدا ان في الجمعيه الشرعيه احنا عندنا 27 حضانه على مستوى الجمهوريه، فيها 1350 حضانه تعمل مجانا. كان عندنا 6 ريت كام بتفحص الاطفال حديث الولاده. جبنا جهازين في الفتره الاخرانيه 8، وان شاء الله المشروع خلال 6 اشهر كل حضانه هيبقى فيها ريت كام، وبنتعاقد مع اخصائي او استشاري رمد يبص على حنين البريتان اللي هم اتعرضوا للاكسجين اللي لابوا تو ريتينوباثي اوف بريماتوريتي. عشان المشكله انا بس الموضوع ده قلت للدكتور نهال عشان ال 16 دكتور اللي حصل لهم مشكله علشان العيانين الريتينوباثي، وكنا بنخرج العيانين وما نقولش حتى يتفحص بره. لا دلوقتي لازم في بروتوكول اتحط امتى هنفحص الطفله في اليوم الكام واليوم الكام واليوم الكام، ولو لقينا حاجه امتى ريفيرت. فانا بشكر الاستاذه الدكتوره نهال على الموضوع الجميل، والدكتور عفاف طبعا ما فيش حد ما يعرفش سيرفاكتنت يخش حضانه ابدا. ماشي الدكتوره هاله هتتفضل تقول كلمه. اتفضلي.
أنا دكتورة نهال بصي استمتعت جدا جدا بالتوك بتاعتك. على فكرة احنا عادة فعلا لما بنسمع تخصصات مختلفة ريليتد لشغلنا بس مختلفة عنا، حقيقي بتبقى الفايدة كبيرة قوي. أنا نفسي تقولي لنا في 2-3 مسج واضحة. احنا كبيدياتريشن خلوا بالكم من ايه، ادوا يعني لو بيشنت او بريماتشور مش في الجمعيه الشرعيه في البرايفت سكشن، هقول له روح امتى او اطلع من هنا على اوفثالمولوجيست على طول، او لما تلاحظ ايه تروح لاوفثالمولوجيست. عايزه الرساله دي قوليها لنا واضحه توصل لنا كلنا.
هو باختصار حضرتك الانفنت لو اتولد 1500 grams to 1750, this is high risk, has to be examined. 31 weeks أو أقل من 34، إحنا في مصر أقل من 34 has to be examined. Infant اتحط على oxygen supplementation for more than 50 days حتى لو هو birth weight بتاعه كويس has to be examined. دول اللي لازم يبقوا to be examined. طب وين؟ اتولد من 4 ل6 أسابيع after his birth. لو مش طالع يبقى الأوفثالمولوجيست يجي لحضرتك من 4 ل6 أسابيع.
كده المعلومة واضحة جدا. ميرسي.
في سؤال ورا؟ أي اتفضل.
السلام عليكم. الدكتور استخدمت الديفيزوماب اللي هو الافاستين كانتي انجيوجينيسيس بالنسبه للفاسكولار اندوثيل جروث فاكتور، فهو ايه الميكانيزم اللي اشتغل واحنا اصلا عايزين نيو فاسكولاريشن وهو انتي انجيوجينيسيس اصلا؟ الافاستين.
حضرتك أنا قلنا الأول الفيجاف.
ايوه
الفيجاف حضرتك بيحصل لما البيبي بينزل في جزء لسه مش فاسكولار الريتنا، ده بيحصل هايبوكسيا. هايبوكسيا هتinduse فيجاف. الفيجاف this time will not induce retinal vasculature normal. لا، هي induce الهاي فيجاف will induce abnormal retinal vessels. This abnormal retinal vessels معاها fibrosis هتشد على الريتنا تؤدي إلى retinal detachment blindness. تمام؟ فإحنا we inject الأفاستم تعمل إيه؟ anti فيجاف. هتقلل الفيجاف هيقل الفاسكوليتشر الابنورمال.
شكرا.
Thank you.
دكتور محمد المليك لي سؤال. اتفضل يا دكتور محمد.
بس انا ببقى سعيد اما احضر مع الدكتوره نهال، حضرت معاها مؤتمرات كتير، واللي يحب يبص الملاك ماشي على الارض يبص للدكتوره نهال.
دي حقيقي 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 يا دكتور محمد.
الموضوع فيه يا جماعه هيريديتري فاكتور، يعني في جينيتك فاكتور في الموضوع، ان البي جي اف والانسولين لايك جروث فاكتور وحوالي 45 ل 50 لوكس لقوا ان هم فيهم بوليمورفيزم، الانتر اكشن ما بينهم لسه مش مفهوم تماما. عشان ما تستعجبش لما تلاقي ولد فيه كل الريسك فاكتور وما حصلوش اي مشاكل، وطفل تاني من غير الريسك فاكتور ما تبقى سو سيفير ابتدت تحصل له المشاكل. فهو واحد من البوليجينيك ديس اوردر. البوليمورفيزمز اللي ربطوها الى حد كبير موجوده كتير في مصر، عشان كده مهم جدا لقيت الدكتوره نهال ان انا فعلا الفولو اب بتاع العيان سواء انترا ان اي سي يو او بعد الان اي سي يو. هي بس النقطه البسيطه اللي انا حبيت اضيفها.
شكرا يا دكتور محمد. شكرا. اتفضلي.
بس عايزه اسال على الاريثروبايتين، هل في اي له دور ولا حاجه؟
It is also claimed that erythropoietin, when it is given, it increases the risk of retinopathy of prematurity. So again, this baby should be screened. كل الفاكتورز حضرتك اللي قلناها دول they have to be screened. They have either حضرتك هتقولي لهم after NICU to be discharged لو حصل ان ال 4 to 6 weeks هيبقى بعد ما يطلع من النيكيو يبقى يجي to be examined. If he is still there in NICU and you cannot get him out of the NICU, an ophthalmologist should go to the NICU. It's a must. احنا we screen all babies totally free of charge. ممكن بيجي لنا حوالي 60 to 70.
بس في اسكندريه تعالي لنا هنا.
اسكندريه.
شكرا.
بس كله free of charge يعني.
طب هنكتمل